New Zealand har siden 80'erne foretaget en social koldbøtte. En liberalistisk politik medførte omfattende privatiseringer. Blandt andet forsøgte man at drive sundhedssektoren som forretning. Det lykkedes ikke. Efter store menneskelige og økonomiske omkostninger er man vendt tilbage til hospitaler som offentlig service. Men prisen var høj, og der er lang vej igen, før New Zealand atter er et velfærdssamfund.
In the early 1990s, I went to America for 3 years, and when I came back, I could barely recognise the New Zealand healthcare system. I just was completely blown away.
The claims that were made for the health reforms in New Zealand were the same sort of claims that were made for privatising our railways, our airline, our electricity system. We were told that if our hospitals competed against each other, if our doctors and nurses competed against each other, that they would have an incentive to provide a better quality health service to New Zealanders.
And they completely changed the direction of New Zealand from a caring welfare state to a right-wing individualistic state where you look after yourselves, where the state was considered to be something bad. We were told that the state had to get out of people's lives, that we had to make our own lives, we had to make our own decisions. I sailed out of Liverpool for 5 or 6 years, and at a ship's party I met a girl who I eventually married, and unfortunately the first child that was born was a microcephalic. Johnny came along and he was also a microcephalic, and when Johnny was 6 months old she got out of bed and dressed Marita and put a bottle in Johnny's mouth and walked out, and we never seen her again. I was treated very well by the Department of Social Welfare. But as the years went by and more people got on unemployment, more people got on the DPB, I noticed that the service that we got became less and less.
Vi kom til New Zealand i august 2000 for at realisere en af vores gamle drømme, så vi købte 26 ton land, vores ejendom her, hvor vi lavede en bed and breakfast, og samtidig har vi et arbejde inde i Fangeray, hvor vi arbejder med rehabilitering af mennesker med traumatiske hjerneskader.
Jeg er uddannet socialpædagog, og så tænkte jeg, et eller andet må jeg kunne lave. Så jeg fik job på et plejehjem, og det havde jeg i 6 uger. Og det er det værste job, jeg i mit liv har haft. Plejehjem her, de er privatejet, og det er en forretning. Så jeg fik skæld ud hver eneste dag, når jeg havde brugt tid på at vaske folk, og havde spildt tiden med at tale med de gamle, mens jeg gjorde det, i stedet for bare at få dem vasket og spulet og tørret ud, og så ind med den næste. Og når de så var blevet vasket og havde fået morgenmad på rad og række, så blev det sat op i sådan nogle grønne vinyllænestole og fik et bælte på, så de ikke kunne rejse sig op. Dem, der selv kunne gå rundt, de blev medicineret, så man var sikker på, at de blev i den der lænestol. Og når man så gik, så var det ligesom sådan en gyserfilm. Alle de her gamle hænder, der sådan strakt ud efter en, bare for at få en lille bit smule kontakt. Og jeg tudede simpelthen hver dag, jeg kom hjem, og til sidst siger Ove, det kan jeg simpelthen ikke holde ud at se på. Så må vi leve af de tomater og så hønseæggene. Hellere det, end at du ser sådan ud i hovedet, når du kommer hjem.
I begyndelsen af 90'erne var målet at privatisere hele sundhedssektoren. Man gjorde sig store anstrengelser for, at hospitalerne skulle give overskud.
Health was commodified. It was looked on as being a service, a product that could be measured and organised in the same sort of lines as a factory.
And they brought in business people And they brought in a system called managerialism, which was designed to run business corporations. And there was a clash of cultures between the business culture and the ethical culture of medicine. And the two were incompatible.
Charge nurses had been replaced by more of a coordinating nurse, so that in fact the control of a budget was not with the director of nursing or with a charge nurse, but with a manager.
When they came in, they looked at the books and they said, 80% of what we're paying is salaries. That's too much. So we'll take all the senior nurses and we get rid of the senior nurses.
It's cheaper to have a smaller number of registered nurses who are paid at a certain level and a larger number of non-registered or caregiver staff that are paid much cheaper. This was a politicisation of nurses in a huge way, that suddenly they were exactly the same as any other worker. You know, they could be dismissed, their wages and conditions were under attack. For the first time we were there on picket lines with the cooks and cleaners and caretakers and grounds people and maintenance people in a way that had never happened before. Instead of being a general hospital, they became divisions. The mental health division, the women's health division, the general surgery division, which meant, if you followed on with the extension of that thought, that these areas could be sold off to private industry.
Some services had to be withheld, so a profit could be declared at the end of the year. The flaw in this, of course, is that no hospital could, in good conscience, have money sitting in their funds and not be providing services. There's a disconnect between the philosophy of the system and the human reality of it.
And there was an example in my hospital where a charge nurse felt that she could save a matter of several $100s out of her annual budget by no longer having paper napkin trays on for the lunch service, you know, so people just got the patients got their tray without a napkin. Madness, complete madness. You know, what did this do? It saved $200 off her annual budget.
A lot of the nurses that I worked either retired, started up real estate agencies, sold chocolates. I went into mental health nursing again, which is another area of my profession. I was lucky I was able to shift sideways. So it was a really bad time. I was at one stage seen by a consultant psychiatrist because I was convinced that I was depressed, but he said I was quite normal. The new model only lasted a very short time before they had to reconstruct it because they saw how dangerous it was and how incomplete it was.
Det lykkedes ikke at privatisere de offentlige sygehuse. Men der er stadig mange områder, der er på private hænder.
Problemet for os er jo, at det er svært at arbejde for et privat firma, som er registreret på børsen og som skal give et overskud til aktionærerne, specielt når det er mennesker, man snakker om.
Jeg har lidt svært ved for eksempel, at vi nogle gange ikke kan lave en ordentlig frokost til vores klienter i bofællesskabet, fordi der simpelthen ikke er penge til det. Og så må de få pandekager til frokost, fordi der skal jo være til aktionærerne. Der skal ikke nødvendigvis være til klienterne.
Den her stamme, der lå.
De mange nedskæringer havde ført til, at folk, der havde råd, købte privat sygeforsikring.
There was a huge growth in private insurance, private medical insurance at that time, because people saw that the public health system was under huge attack. You know, that there were ward closures, there was downsizing, there was this whole thing about being able to save a huge amount of money on health.
Heroppe i Northland, der er gennemsnitsindtægten for en familie $15.000 om året, det vil sige 60.000 kroner. Og det kan være meget svært at spare op til en forsikring eller en pension. Så er statens holdning, kan man ikke selv spare op til de der ting, jamen så må det være familiens problem at tage sig af en.
Willie has been a healthy boy since last year. He's never sick. Is he on breast milk? Breastfeeding?
Breastfeeding still.
Still breastfeeding. Good, Mum. Good.
And the mobile bus came into being probably 6-7 years ago in order to take the service to the community. Basically the community that through lots of different reasons are not able to avail themselves of the service. Plunkett was often seen as being an organisation for the white middle-class people, the people that wanted to have their children seen on a regular basis would access the service, and the people that weren't as familiar with it and comfortable with it would not. For example, the Pacific people, the Maori people and migrant people were not comfortable with our service. So we've had to make changes in order to meet their needs.
Turn his face to people talking.
Yeah.
He's too young for witness.
No, we just started it.
Yeah, but it's better to stop it.
There are diseases that have cropped up, such as meningitis, and probably more higher incidence of tuberculosis. And it's due to lots of factors.
We've gone from 5 to 14, 15. I've got my cousin and her family at my house who are waiting to move into their own home. And yeah, so I've got a full house now. Not only the neighbours' kids, but I've got my cousin and her children, so it's fine. But the space. Now, this is where we live, my family and I. And my grandchildren and my daughter and my cousin Ngahui lives in here, and her family and her husband and the children live out here. And they should be playing and doing a bit of homework and showing the children numbers, or especially Calvin. Sometimes I wish I could win $1 million, but I don't put money onto it. So. The line is broken enough. Don't put your hand down there. They're good kids. Their kids are good. See, they're not in here. You know, they've got 6 children and they're not in here. Usually all kids sort of like swamp the house, but these kids, they've got homework to do and they've got to do it. And she's really, they're really good. Oh, my children are okay. They're not too bad, really. It's just
There's so many obstacles that get in the way of children's health. And they absorb the family's energy, really. Like if you're looking for a house, you're looking for enough money to put food on the table for your children, all those sorts of things. If you haven't got a telephone, those become the priorities, not the children's health. It becomes survival mode, not living. So I think we're slowly moving out of the survival mode into living.
It costs you a lot less than what it used to, $25 to $30, $40 at times for people to go to see their doctors. Now it's only, for children is nothing, and for adults it's $10, and who can complain about that?
Hi, I'd like to welcome you to St George's Private Hospital, which is the largest private hospital in New Zealand. And now I'd like to take you on a little tour inside the hospital, show you some of our amazing facilities. This is Dawn, who's the CEO's private secretary and runs a very, very efficient hospital. She does. She's here from sort of Sparrow, whatever. So if you'd like to have a look around in here, the beds operate. There is a switch here which saves the nurses lifting the patient. The bed goes up and down automatically itself. Oh.
That's calling for a nurse, so maybe I'll get a nurse in here and she can show us how the beds work. The TV, which has Sky TV, so it gets numerous channels for the patient. Could you show us how the beds work? I haven't got the control here. And this is one of the nurses at St George's, and this is one of the choice of uniforms they have. They can mix and match them.
Right. Feet can be raised, and eventually it will come up. Okay.
And you can see how efficient the bell works. When I rang for a nurse, she was here within about 30 seconds. So the service is very good as well in here.
We pretend here that we have a public health system and that people have rights of access. It's not true. You don't as of right in New Zealand because of the way we've set this up, because of our low tax economy, because of the intrusion of private health into the arena of public health. We do not now have a citizenship right to access health. Your access to health is determined on the basis of income. Unless it's for a life-threatening condition. If you have a heart attack, yeah, you'll go to the public hospital. If you've got pneumonia, you'll be able to get into the public hospital. But unless it's a life-threatening condition, your access to healthcare is determined by your income.
New Zealand har en offentlig ulykkessikring, ACC, Accident Compensation Corporation. Det er for at undgå amerikanske tilstande, hvor folk sagsøger hinanden.
Generelt er det sådan, hvis man skal blive syg i det her land, så skal du komme ud fra en ulykke.
Ja, det skal man helst.
Fordi så er du dækket af den
ACC.
forsikring, som alle er dækket af.
I was dancing. It was 2 years ago now. I thought I was 21 again. I was trying to rock and roll and all this jazz, and I come down badly on my foot. And I thought, that doesn't feel right. So I sat down, and it was quite painful. Anyway, I'd had a few grogs, and I walked home, a bit painful. Woke up in the morning, oh, God, painful, eh?
I fell off my roof at home on my day off. I was cleaning the chimney, and the ladder went.
They're going to have to take that foot off, which doesn't sound too good to me. I'm fighting that. I turned it down 6 months ago, and you're allowed to do that, so I did. But it hasn't come right, so I'm thinking now maybe I'm going to have to do that.
ACC pays for the whole lot, except for 1 week's wages, because it was an accident I did at home. They don't pay the first week, but my work pays me sick leave for the first week. And my mortgage gets paid.
There is 2 4-bedded rooms on each floor. Quite often the ACC patients go into the 4-bedded room because obviously they're not paying patients.
New Zealand har sin helt egen måde at takle problemet med ventelister.
We took from the waiting list, or they took from the waiting list, everybody that couldn't be operated on within 6 months, and they threw them off the waiting list.
So what happens now is a primary care physician will refer someone, and they'll be evaluated, and if they have enough points, if they're deemed to be ill enough, they'll go on the waiting list. If they are not, they don't go on the list at all.
The government then said, isn't this marvellous? It's only a 6-month wait for an operation in New Zealand.
There was a guy that had a hernia, a testicular hernia. His testicle was the size of a watermelon. And this guy didn't qualify for an operation because he wasn't in acute danger. That's right, but he was extremely uncomfortable. He couldn't walk. He was basically bedbound, but he didn't qualify for an operation. But the waiting list was reported as having been reduced. And that applies, you know, it was obviously had some sort of salacious value, and we got it on the TV news, and in the end he got an operation just because of our advocacy for it. But there are lots and lots of people like that.
You need to make some good money to keep them up to date with the equipment and the facilities, because, you know, especially, as I said, there is competition with another private hospital in the city, and that competition is healthy because it actually makes you improve everything yourself.
I 1990 blev der vedtaget en lov, ECA, Employment Contract Act, der gjorde det af med kollektive overenskomster og gjorde det op til den enkelte selv at forhandle løn og vilkår.
As a result of that was, rather than having one national agreement for nurses and midwives, as we had for a very long time, we ended up with more than 21 different agreements.
It also put nurses against nurses, and this was part of this competition. You know, come to Auckland, we'll pay you more than Southland, and all this sort of rubbish. And so it's taken us 10 years to bring us back, and we're finally, as of just in the last few months, we're finally back into a national, or getting near a national collective contract again, which means we're a stronger bargaining unit.
We also had governments which decided to get rid of our free education system and to charge people for a tertiary education, which meant that not only have nurses, for example, been paid less than their worth and been competing against each other, but they are also now having to pay to train. And the average nurse leaves their university training with a $20,000 student debt, which they have to pay out of their relatively low incomes.
Og så må vi have tjekke, om der er nogen æg.
Hvis du for eksempel kommer ud for en dag, at din klient har meldt afbud til den appointment, du har haft, eller det møde, du har haft, jamen så får du ingen penge for det, fordi så er du jo ikke på arbejde. Det kommer man ud for ret tit, så du kan ikke sige, at du har en fast indtægt. Du har en meget variabel indtægt på det, vi laver.
Vi er jo også heldige, fordi vi har en lille sideforretning her i vores bed and breakfast, som så er begyndt at køre rimelig godt. Så det vil sige, nu har vi sådan en lille indtægt ved siden af. Men for folk, der er totalt afhængige af sådan et job, der er det jo svært. Og mange af vores kolleger arbejder i 2 og 3 jobs, og det er mest enlige kvinder midt i 40'erne, midt i 50'erne, som er alene med børn, og som forsøger desperat at få en familie til at hænge sammen. Og mange af dem kører både 2 og 3 jobs, deltidsjobs, simpelthen for at have nok til at bare overleve på som en lille familie.
People that provide healthcare, and that's the professionals in the public health system, actually have a huge amount of goodwill towards that system that the general management system could not take account of, because it's not something you can put on a balance sheet. You don't know that you've lost it until it's gone. And a lot of that is gone. The mentality of a lot of people in the public health system now is they've cared nothing about me for the last 10 years, so actually I don't want to go that extra mile. I'm not going to stay any longer than my shift time is. I'm not going to come in after work. I'm not going to come in early. If they're short-staffed, I don't care, because they don't care about me.
So what we're trying to do is address pay and workload and encourage young people back into nursing. And I'm optimistic that we can do that. It's going to cost a lot of money, but currently it's estimated we spend $100 million a year, 100 million, on turnover of nursing staff. Can you believe that? What a waste of money. And so we're saying let's put money into paying them better and having more of them. We also think that if we get better ratios, we'll have less patient falls, less infection rates, better staff morale. So yes, it's going to cost money to put in more staff and pay them better, but that's money that at the moment's being wasted, so let's shift the money.
The compassion's gone out of the welfare system. The compassion that used to be there has gone. When I first went on the benefit in the 70s, the officers and so on were trying to help me. Now nobody bothers, you know?
It's my dad, his little baby. Here's my grandfather. There's my mum on a ship. That's my money. That's my mum.
At the moment I get nothing because I'm now over 65, so I get the national superannuation. So really I don't get anything for looking after Marita and John because at 65 I'm the same as or 67 I'm the same as every other national superannuited, and I should be sitting down in my chair smoking a pipe and looking at the scenery, but I don't get.
I've been in this job for nearly 10 years. The trick about this job, put your money away, give the drugs up, and look after your children. That's all I can say.
New Zealand, they've got a fair bit of unemployment. Those people cannot afford to pay that insurance. That's all there is to it.
There's too many people that'll just fall by the way and they won't even get looked at and looked after, and it's all right for those that have got money and that can afford the insurance premiums, but there's a lot of people in New Zealand that certainly can't afford the premiums, and they're the ones that'll suffer.
I've worked 45 years and I reckon I've paid for all these things. That's what they told us it was for.
Unless you've got a memory of what it was like before, it's very hard to build a social consensus around universality. And at the moment, I think it's probably a generation before we can get back to what is in effect, what is a more humane system and also is a more economically efficient system.
We should be running the health system like we run our budget at home. Sometimes we have to invest in things that are difficult to afford, but we know that we have to do that in order to make savings down the road. If we keep putting these things off, then they come back and they're more expensive. It is not an efficient way of doing things.
There have been improvements. There has been a lot more money going into primary health care. A lot of low-income communities now do have much cheaper health services in their own areas, but that needs to be done much more quickly and it needs to cover everybody.
The society shall be judged on the way that it treats the most vulnerable of its citizens. So if we treat the most vulnerable of its citizens right, then we've got the building blocks to build a better society.